Hello guys, welcome to this discussion where we are going to discuss about diabetes insipidus. It is a Harrison based discussion and this discussion is completely designed in a such a fashion that completion of MCQ will lead to completion of the chapter. Okay, so it is completely from Harrison and we are going to discuss today about diabetes insipidus. So what is this diabetes insipidus actually? So it is actually disease of polyuria. Polyuria means urine of more than 3 liter per day. Okay. So this diabetes insipidus was earlier described or currently even in practice described into two types. One is central diabetes insipidus, another being where the defect lies at the level of kidney where dilution mechanism is impaired, called to be nephrogenic diabetes insipidus. But these two pathology doesn't signifies, this nomenclature doesn't signifies the pathology related to it. That's why current dictum is to term central diabetes insipidus is something which is which is ABP or arginine vasopressin deficient diabetes insipidus, and nephrogenic diabetes insipidus to term something as arginine vasopressin resistant diabetes insipidus. Okay. Okay, so deficiency of ADH hormone, which is produced in that's released from the posterior pituitary and produced in the hypothalamus, it manifests as defect in the counter current mechanism in the kidney, resulting in excessive of diluted urine. Okay, so this ABP is actually synthesized in hypothalamus, where in the hypothalamus it is secreted in paraventricular synthesized in paraventricular and supraoptic nuclei of hypothalamus, a very star point for consideration. Okay, now coming to the first question. Okay, before going into that, so how do you define diabetes insipidus? We define diabetes insipidus clinically when urine output is more than 3 liter per day or something more specific of 50 ml per kg for 24 hour per kg per hour for 24 hours, and 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 if the urine is hypotonic, that is it is diluted urine. So how do you know it is hypotonic? If urine osmolarity is less than 300 milliosmol per kg. Okay, all right. So this is the way how do you define diabetes insipidus. Problem arises, there can be increase in urine output although urine can be hypertonic. What do we call it? We call it to be solute diuresis. So when does it occur? It occurs in the real diabetes, that is diabetes mellitus, when there is increase in the sugar load at the level of the kidney. It occurs due to use of SGLT2 inhibitor like drug, where there will be increase in the sugar at the level of kidney, or when there is increase in drugs or osmotic drugs which causes solute diuresis. It can be also seen with use of drugs like mannitol. Okay, all right. So as the question says, all of the following are causes of neurogenic diabetic insipidus except. So options are cerebral hemorrhage, pregnancy, SE aneurysm, meningitis. Okay. So, coming to the causes of diabetes insipidus, central one, also called as neurogenic diabetes insipidus, can be due to congenital causes, right? So it can be due to congenital causes, it can be due to drugs, it can be due to some infection at the level of the brain or cancer at the level of the brain, which we call as to be more common one to be craniopharyngioma associated. It can be autoimmune like lymphocytic histiocytosis related causes. Okay, sometimes even post surgery traumatic cause can relate to central diabetes insipidus. All right. So when we call congenital cause, first thing that should come in mind whether it is autosomal dominant, autosomal recessive or X-linked disease. Remember, most of the cases are autosomal dominant in nature due to ABP gene mutation But you should remember one of the cause which is autosomal recessive mainly, which is given by the name of Wolfram syndrome, which is not only diabetes insipidus, but it contains diabetes mellitus and optic nerve atrophy along with diabetes insipidus. So it is remembered by the mnemonic DIDMOAD disease. So diabetes insipidus, diabetes mellitus, optic atrophy disease, Didmore syndrome, Wolfram syndrome. It is seen due to mutation of WFS1 gene. Alright, okay. Now coming to the other causes can be drugs like ethanol, granuloma can be due to sarcoid granuloma. Sarcoid, by the formation of granuloma, can cause central diabetes insipidus. By causing hypercalcemia, can lead to nephrogenic diabetes mellitus. Then it can be due to infection like meningitis, TB, or post-encephalitis syndrome. It can be due to pituitary tumor or metastasis or craniopharyngioma, and it can be post-surgery. Among nephrogenic diabetes mellitus, causes are again congenital causes, which is mostly X-linked recessive. It can be drugs like lithium and cisplatin acts at the level of the kidney and causes nephrogenic diabetes mellitus. Then what you need to know, hypercalcemia or increase in calcium or hyponatremia, hypokalemia can lead to nephrogenic diabetes insipidus. One very specific phenomena which is neither congenital central neither nephrogenic is seen in pregnancy. What happens in pregnancy? In the period of pregnancy, there is increase in arginine vasopressin metabolism peripherally, resulting into decrease in arginine vasopressin in the circulation and resulting in diabetes insipidus. So this form of due to increased metabolism is seen in pregnancy, which is neither neurogenic or neither nephrogenic cause of diabetes insipidus. All right. So coming to the causes. Now these causes, as you can see from the table, so there are central causes and nephrogenic causes. There are congenital acquired in both the variety. Congenital nephrogenic is X-linked, as you can see here, X-linked, and congenital is central, can be autosomal dominant and autosomal recessive. Autosomal recessive one we know by the name of Wolfram syndrome. Wolfram syndrome. Okay. So Wolfram syndrome is due to mutation of WFS1 gene. All right. Okay. So here the drugs like lithium F is the acquired cause of nephrogenic diabetes insipidus. What does it cause? It actually increases the expression of aquaporin 2 protein. So sorry, it doesn't increase, it will decrease. It will decrease the expression of aquaporin 2 protein by causing resistance to vasopressin and impairs the urine concentration, which results into nephrogenic diabetes insipidus and polyuria. So the main mechanism involving aquaporin 2 is that, or the lithium per se is that it inhibits the signaling pathway that normally moves aquaporin 2 channel to the cell surface after B2 receptor stimulation. All right, after B2 receptor stimulation. Okay. So it decreases the aquaporin 2 resulting into concentrated urine. Okay. Now, as you can see here, V2 receptor here, this V2 receptor is a G protein coupled receptor, actually remember this thing, and it is located in the principal cell of the renal. This is the renal collecting duct, and considered to be the principal cell. And here the vasopressin, these are the vasopressin moiety. Here the vasopressin binds to the B2 receptor. Okay. So it activates the adenyl cyclase CAP protein. So it activates the adenyl cyclase, which is a CMP protein, by protein kinase A, and by this signaling pathway, it causes increase in aquaporin 2 in the basolateral membrane or the apical membrane of the collecting duct cells. That's why there is increase in water permeability. So there is increase in water permeability resulting into concentrated urine. Okay. Okay. Now, aquaporin 2 is not a receptor but a water channel protein. So, its expression and membrane localization are directly regulated by V2 receptor expression, V2 receptor activation. So, V2 receptor is activated by vasopressin. So, when these aquaporin channels are inserted into the cell membrane through this V2 signaling, more water passes through the cell, which is critical for the antidiuretic effect of the vasopressin. So dysfunction of the system at any level, will result into nephrogenic diabetes insipidus with excessive urine production and inability to concentrate urine. Now, if there is no vasopressin at all in the circulation, so the production factory in the brain, in the pituitary or in the hypothalamus is restricted for some reason, or there is increase in metabolism in the circulation, that's why vasopressin is less in the kidneys, it will result into central central form of diabetes insipidus. Okay, it will result into central form of diabetes insipidus. All right. Okay. Now coming to the next question. 40-year-old woman is presenting with headache, diplopia, and weight gain. All right. So there is headache, diplopia, weight gain, fatigue, cold intolerance, and menstrual irregularities. Reports excessive thirst and passes nearly 10 liters of urine per day. So water deprivation test is this. So this test is the diagnostic test, you can say, for polyuria. So what will be the pattern of urine osmolality and what will the effect of intranasal desmopressin administration? Okay, so this is very important question. So before going into deep, if you look clearly, what is this question saying about? This question is saying about patient is having headache, diplopia, weight gain. Okay, so this headache plus diplopia suggest that there is some sort of compression in the pituitary region. That's why there is optic chiasma effect. So it is most likely a case of pituitary tumor. Okay, pituitary tumor causing mass effect. All right. Now there is weight gain, fatigue, cold intolerance. What are the sign of? Along with menstrual irregularities, these are sign of hypothyroidism. Not only hypothyroidism, there can be hypogonadism as well as because of menstrual irregularities part. So these are nothing but signs of pan hypopituitarism. Why it is same? It is due to the shock effect of pituitary tumor. All right. And there is polyuria and polydipsia. So excessive thirst and nearly 10 liters of urine per day. So polyuria and polydipsia, it is diabetes insipidus. So it is a disease, in structural disease of the pituitary, where there is increase in the size resulting into mass effect. There is involvement of anterior pituitary as well as the posterior pituitary. Okay, this posterior pituitary effect can be due to the stroke effect as well. So what is the most likely diagnosis? Most likely diagnosis, patient is suffering for pituitary macroadenoma. It can be craniopharyngioma, which is causing central diabetes insipidus, which is our concern. So what are we going for? We are going for water deprivation test. So understand this, guys. If someone is not producing enough of ADH, so what will happen when you deprive the person from the water? Even you deprive, urine will not be concentrated. Why not concentrated? Because concentrated mechanism is failure. Because there is no arginine vasopressin. Even you deprive the patient, here in the central causes of diabetes insipidus, urine osmolality will remain unchanged. Okay, so understand this urine deprivation test. So urine deprivation test. So what happens in case of central and what happens in case of peripheral and psychogenic? In case of psychogenic, when the patient is actually taking lot of water and peeing lot of water whole day, in such cases, when you deprive the patient from the water deprivation test, when you deprive the patient from water, it will result into concentrated urine. Then, in case of central or nephrogenic DI, what will happen in both the cases? Both the cases, when you deprive from water, urine will be still diluted. So urine will be diluted. So urine osmolarity will remain unchanged. That is, it will remain low. Okay, it will remain less than 300 milliosmol per kg. Now, how to approach these cases? Next step is differentiate between central and nephrogenic. Give intranasal desmopressin. Intranasal desmopressin or synthetic ADH is given to this patient, which is nothing but synthetic ADH. Okay. So when you give synthetic ADH, look, receptor is working absolutely fine in case of central cause, but in nephrogenic diabetes insipidus, there is issue with the receptor level. So if urine osmolarity, that is urine become concentrated or osmolarity increases, what does it mean? It means it is a case of central diabetes insipidus. Because why? Receptor is absolutely fine. So when you give synthetic desmopressin or synthetic ADH, it is working on the kidneys and resulting into concentration of the urine. So it is nothing but a case of central diabetes insipidus. But even after use of intranasal desmopressin, if urine osmolarity remains low, it means it is nothing but nephrogenic diabetes insipidus. Okay. Okay. So that's why how we differentiate the cases. Now coming to the question. So as it is a pituitary tumor and we know pituitary tumor is responsible for central diabetes insipidus. So initially, even after water deprivation, urine osmolarity will remain unchanged. But after use of desmopressin, it is supposedly going to increase. All right. Okay. Now coming to the next question. A 38-year-old woman with polyuria 12 liter per day and polydipsia is undergoing a water deprivation test. Her urine osmolarity remains at 90 milliosmol per kg throughout deprivation and rises to 40 milliosmol per kg after intranasal desmopressin. So the same question which we discussed, it is nothing but a central diabetes insipidus. All right. Okay. Now I'm coming to the next question. Okay. So a man is having polyuria with water deprivation test. Baseline urine osmolarity was 150. After 6 hour deprivation 290. After desmopressin it is 360. So there is response with desmopressin. But even after use of water deprivation, it has not rose more than 300. So this is not a normal case. This is not a normal case. This is not a primary polydipsia. This thing is rolled out. Okay, but it is a case of central DI. Why central DI? Because there is response to desmopressin. Now problem arises to differentiate between complete and partial. Now you can see water deprivation test is giving a partial response. So this is a case of nothing but a partial diabetes insipidus of central origin. Little bit of tougher set question, but I think you should know at least three. Now coming to this table for approach of polyuria. So first of all, when there is polyuria or when there is 3 liter of urine per day or urine output is coming more than 50 ml per kg, 50 ml per kg. So in such cases, next step is to check for urine osmolarity. So if urine osmolarity is more than 300, it is case of a solute diuresis. So there is excessive solute in the urine which is putting lot of water along with it. What are the common causes? Common causes glucose, common causes mannitol, and common causes acute tubular necrosis with a diuretic phase. Okay, diuretic phase in a post-acute Okay, during resolution, there is diuretic phase where there is solute diuresis resulting into such features. Okay. Now, when urine osmolality is less than 300, which we take, so the probability in such cases for us is can be psychogenic polydipsia, it can be central diabetes insipidus, so it can be psychogenic, it can be central or nephrogenic. All right. So how do you differentiate? Go for water deprivation test or ADH level. By this, if history is also suggested, it can be psychogenic due to primary polydipsia. So it can be psychogenic in nature. Okay. Now, once this water deprivation test is negative, that is urine is still coming diluted after water deprivation, it is diabetes insipidus. So how do you differentiate central versus nephrogenic? So so just check into the vasopressin sensitivity by intranasal desmopressin. Central DI will be vasopressin sensitive, whereas nephrogenic DI is vasopressin resistant. Okay, so that's how we usually approach the cases of diabetes insipidus. Now coming to the treatment part, for the sake of completion, remember any case management option is always to have water. Because they feel thirsty, you need to give water and you need to check for sodium so that there is no cases of iatrogenic hyponatremia. One wonderful treatment line is use of thiazide diuretics. So what does thiazide diuretic causes? Thiazide diuretics acts on the luminal surface at the sodium chloride co-transporter region and it enhances sodium delivery resulting into loss of sodium and water. So there is diuresis with use of thiazide diuretics, and it helps in case of this diabetes insipidus. So treatment of, if I come into the treatment of central DI, how do you treat? There is no ADH. Easy answer. Replace the ADH. ADH replacement. This ADH replacement is done by desmopressin. Okay, desmopressin. So it can be intranasal spray, which is usually preferred. 10 to 20 microgram is given per spray, one puff, and it is given per day. One puff is enough. One to puff and is enough. There is oral tablet available, 0.1 to 0.4 milligram. It is given 2 to 3 times a day. What does it do? It acts on the V2 receptor in the collecting duct, increases the aquaporin to protein channels, increases uptake of it into the into the collecting duct, resulting into increase in water reabsorption. Okay. Apart from that, there are some rules of thiazide diuretics. There are some rules of low solute diet, and there are rules of carbamazepine and chlorfibrate because it stimulates ADH release, but it is morely seen in case of partial central diabetes insipidus. Okay, so you need to monitor serum sodium because if there is risk of hyponatremia. Now coming to the nephrogenic, so best strategy in the treatment of nephrogenic is to remove the cause because most of the causes are usually irreversible. But sometimes due to lithium toxicity, which is occurs after 10 to 20 years of lithium use, when this nephrogenic diabetes insipidus is seen, even after stopping lithium, it is not reversible, symptom persist. Okay. So in such cases, we opt for treatment. Treatment may involve thiazide diuretics or NSAID. What does NSAID do? NSAID decreases the prostaglandin at the level of the kidneys and resulting into increased action of the ADH into the collecting duct. Although these rules are questionable, but these are tried. Even amiloride, which is especially for lithium-induced nephrogenic diabetes insipidus, it blocks lithium entry by epithelial sodium channel in collecting duct. So this amiloride via enoch channel in the collecting duct, amiloride via enoch channel in the connecting duct prevent toxicity and improves the water reabsorption. So guys, that's all regarding diabetes insipidus. I feel this is a short topic, easily revisable topic, and I hope if you watch this video in 1.5x or 2x, you can easily cover this topic for your exam. Thank you.